Hello, my name is Alex Herrera from City of Hope. Today I'll be presenting updates in Hodgkin lymphoma from the recent 2020 ASH meeting. I would say that the theme of this year's Hodgkin lymphoma ASH sessions was the integration of novel agents earlier into the treatment of the disease. So this is a summary of the presentation. We'll proceed chronologically. Starting with frontline therapy, we'll discuss the long-term follow-up of a study evaluating brentuximab vedotin-based therapy in elderly patients, showing longer PFS after BV-containing doublets than monotherapy. We'll move on to the salvage pre-transplant setting and discuss a study evaluating anti-PD-1 therapy combined with chemotherapy that yielded an impressive complete response rate. Next, I'll present data from a study evaluating nivolumab combined with BV as post-transplant consolidation in high-risk patients, which produced long-term excellent PFS. And we'll discuss two treatment approaches for patients who have already received prior BV and PD-1 blockade, and round out the presentation with brief reviews of some other notable abstracts. Here are my disclosures. Here's the schema for the SGN 3515 study, which evaluated BV-based frontline therapy in patients 60 years or older who are considered unfit or unsuitable for conventional chemotherapy. Patients received treatment every 3 weeks, and there were 4 arms to the study. Part A evaluated BV monotherapy, Part B evaluated BV combined with dacarbazine, Part C evaluated BV combined with bendamustine, and Part D evaluated BV combined with nivolumab. This table shows the baseline characteristics across the cohorts. There were around 20 to 26 patients enrolled in each cohort of the study. The median age across cohorts was 70 years old or higher. A majority of patients had advanced stage disease. Almost half had extranodal involvement, and almost half had B symptoms, and most had at least some ADL limitation. The bendamustine combined with brentuximab arm was discontinued early due to excessive toxicity, and patients received only a median of 5 cycles. Otherwise, patients who received doublets had a higher median of cycles than monotherapy patients. The overall response rate and complete response rate were similar across the arms, ranging from an overall response rate of 90 to 100% and a complete response rate of 68 to 88%. As you can see at the bottom, and I'll show in the next slide, the duration of response was quite a bit longer for patients who received combination therapy as combined with BV monotherapy. And you can see here on the progression-free survival curve according to cohort that, again, I'd say this is the most important slide in the presentation, showing that BV monotherapy had a shorter PFS, just in the range of 10.5 months, as compared to patients who received doublet therapies. Patients treated with brentuximab vedotin combined with dacarbazine notably had a nearly 4-year median progression-free survival. As expected, elderly patients had a high rate of treatment discontinuation due to toxicity, most often due to peripheral neuropathy. And the different toxicities across the cohorts are shown here in this slide. So to summarize this initial study, BV and monotherapy and BV doublets are associated with similar response rates, but the PFS is longer with BV doublets as combined with BV monotherapy. We need longer follow-up for the brentuximab vedotin combined with nivolumab cohort, but certainly BV plus dacarbazine is a viable option for elderly patients who cannot tolerate combination chemotherapy, and BV monotherapy could function as a palliative option for patients who are too frail to even receive one of the doublets. The next presentation I'll discuss is a study from Memorial Sloan Kettering, evaluating pembrolizumab combined with GVD as first salvage therapy for patients with primary refractory or relapsed Hodgkin lymphoma. Patients had a PET scan after 2 cycles and could proceed to transplant if they were in a complete response. They received 2 additional cycles if they were not in a complete response and could proceed to transplant thereafter. The baseline characteristics for the study are shown here on the right. 39 patients were enrolled. 79% of patients had either primary refractory disease or early relapse. About a quarter had brentuximab vedotin included as part of their original frontline therapy. Here's a flowchart of the patient's disposition on the study. The complete response rate among 37 evaluable patients after 2 cycles was 92%. 29 patients proceeded directly to transplant, and 7 patients received 2 additional cycles. At the end of protocol treatment, the overall complete response rate was 95%, as shown here with the large red arrow. Here's a figure showing the most common toxicities with the regimen. There didn't appear to be any unexpected safety signals, with rash, elevated LFTs, mucositis, and gastrointestinal toxicities being the most common. So to summarize the results from this particular study, pembro combined with GVD produced a high complete response rate, higher than 90%. We need longer follow-up to assess the durability of these responses, but there were no unexpected safety signals. And I think based on these results, a randomized study of PD-1 based versus conventional salvage chemotherapy is warranted. At this recent ASH, we also presented data from our multi-center phase 2 study of brentuximab vedotin combined with nivolumab as post-transplant consolidation after for patients with high-risk relapsed refractory Hodgkin lymphoma. Patients received 8 cycles as opposed to the traditional 16 when BV monotherapy is used. Patients had to have high-risk disease defined as one of the Herrera criteria, either primary refractory or relapsed Hodgkin lymphoma within 1 year of completing initial treatment, or extranodal involvement at relapse. But we did include some of the additional modified Herrera criteria as eligibility points: B symptoms at relapse, requiring more than 1 salvage therapy, for patients who were not in a complete response at the time of transplant. Notably, patients could have prior PD-1 blockade or brentuximab vedotin, as long as they didn't progress while they were on that therapy. Baseline characteristics of the 59 patients enrolled are shown on the right. 90% of patients had primary refractory disease or early relapse. 81% of patients were in a complete response at the time of transplant. 65% of patients had 2 or more of the modified Herrera risk factors. About half of patients had prior brentuximab vedotin. 42% had prior PD-1 blockade. About half of the patients completed all 8 cycles of both drugs here. You can see on the bottom left in the disposition table. 76% of patients completed 8 cycles of at least one of the drugs, either brentuximab or nivolumab. Just under a quarter of patients discontinued all therapy prior to the completion of 8 cycles. 10% of the time it was due to an adverse event. 14% of patients discontinued BV, and 12% of patients discontinued nivolumab early. The 19-month progression-free survival in all patients was 92% after brentuximab vedotin combined with nivolumab as consolidation. The 19-month PFS, according to the number of risk factors, is also shown here in the lower figure, with a 93% PFS after 19 months in patients with 1 risk factor, 96% in patients with 2 risk factors, and 83% 19-month progression-free survival in patients with 3 risk factors. The 19-month overall survival in all patients was 98%. The regimen was tolerable. Peripheral neuropathy and neutropenia were the most frequent adverse effects, and the most common grade 3 adverse event was neutropenia, 31%. Like other studies of PD-1 blockade in the consolidation setting, we did see a bit more immune-related toxicity in the post-transplant setting. Used BV combined with nivolumab as compared to the pre-transplant setting. So 27% of patients required systemic corticosteroids for an immune-related adverse effect, and the most common immune-related adverse effects are shown in the table here at the bottom. So in conclusion, this particular study of BV and nivolumab consolidation for 8 cycles led to 92% progression-free survival in high-risk Hodgkin lymphoma. It appeared that intensifying therapy but shortening the duration was effective. The results are applicable to patients with prior BV and PD-1 exposure. About half of patients had received each of these therapies, which is different than the Herrera study, a study that enrolled patients who were only brentuximab vedotin naive. The regimen was tolerable, but it was associated with more immune-related toxicity than using this combination in the pre-transplant setting. 27% of patients required steroids. And I think based on these results and other studies that have been conducted thus far, PD-1 post-transplant consolidation should be studied further. I wanted to mention 2 studies that evaluated new therapy options for patients with multiply relapsed refractory Hodgkin lymphoma, patients who have previously received BV and PD-1 blockade. One study evaluated the mTOR inhibitor everolimus combined with itacitinib, which is a JAK1 inhibitor. 16 patients were enrolled, and nearly all had failed prior BV and PD-1 blockade. Most had a prior autologous stem cell transplant, and some even had an allogeneic transplant previously, or CD30 CAR T cells. The overall response rate to this combination was 75%. The complete response rate was 12.5%, with the median duration of almost 10 months. Another presentation reported preliminary results from a phase 2 study evaluating camidanlimab tesirine, or CAMI, which is an anti-CD25 antibody drug conjugate with a PBD dimer payload. Patients had to have at least 3 prior lines of therapy, including brentuximab vedotin and PD-1 blockade. Shown on the bottom, you can see that the patients received 2 cycles of CAMI at 45 micrograms per kilogram. And then after the 2 cycles, they received 30 micrograms per kilogram thereafter from cycle 3 onwards for up to 1 year. The baseline characteristics are shown here on the left. And these are it's an expected cohort of patients with multiply relapsed refractory Hodgkin lymphoma who have failed prior BV and PD-1 blockade. The overall response rate was 83%, with 38% of patients achieving a complete response. 11% of patients were bridged to a stem cell transplant. Notably, on nearly 2/3 of patients had a grade 3 or higher adverse event, including 6.4% of patients who had Guillain-Barré syndrome. And that led to a safety pause that was ultimately lifted after a close review of the GBS events. But obviously, evaluation into this particular adverse effect, as well as others, is ongoing. Otherwise, nearly 3/4 of patients had a characteristic skin toxicity that is seen with these PBD dimer payload antibody drug conjugates. There were GGT elevations and edema or effusions noted as well. I wanted to mention a few other notable abstracts from this year's ASH meeting in the Hodgkin lymphoma space. One study evaluated pembrolizumab combined with entinostat, an HDAC inhibitor, in patients with relapsed refractory Hodgkin lymphoma. The study enrolled 17 patients. The median number of prior therapies was 4. Nearly half of patients had had prior PD-1 blockade. 18% had had prior HDAC inhibition. The overall response rate in this study was 94%. The complete response rate was 63%, with a 1-year progression-free survival of 84%, which are pretty impressive response rates in a group of patients many of whom had had prior PD-1 blockade. In the top right corner, I'd like to just bring your attention to the study evaluating BV combined with ICE as first salvage therapy. This was a study from Fred Hutch, evaluating 45 patients, a large proportion of whom were primary refractory. The overall response rate to the combination was 91%. The complete response rate was 74%. And those rates appear to hold up even in the primary refractory group. The 2-year progression-free survival was 82%, and the 2-year overall survival was 98%. So, nice long-term follow-up data from a study that had been initially presented many years ago. In the bottom left corner, I wanted to draw your attention to a 5-year update of Echelon 1. The 5-year progression-free survival after brentuximab vedotin combined with ABD was 85%, as compared to nearly 79% in the ABVD arm of the study. So basically, the results continued to hold up at 5 years. I think the most notable piece of data from this presentation was some data on fertility, showing that there were a similar number of pregnancies in patients across arms. And so, these were preliminary data that it didn't appear that brentuximab vedotin necessarily had a negative impact on fertility. Finally, in the lower right, I wanted to mention a secondary analysis of the Keynote 204 study, a randomized study evaluating pembrolizumab compared to brentuximab vedotin in patients with relapsed or refractory Hodgkin lymphoma. This particular analysis looked at the impact of the number of prior lines of therapy on outcomes. And briefly, it showed that the progression-free survival was longer after pembrolizumab compared with BV, regardless of the number of prior lines of therapy. So they compared patients who received these drugs in 2nd line or 3rd line or later. And the results of the primary analysis that pembro was associated with longer PFS held up, regardless of the number of prior lines of therapy. So to conclude, promising data were reported at ASH 2020 using novel agents and earlier lines of therapy. As I mentioned, we saw BV frontline data in elderly patients. We saw the long-term follow-up showing that BV doublets did seem to be producing, reasonably long progression-free survival, nearly 4 years with BV endocarbazine. We saw PD-1 combined with chemotherapy salvage in pembro GVD, and the CR rates were quite impressive. And we saw brentuximab vedotin combined with nivolumab consolidation after autologous stem cell transplant. And I think, what we're seeing with these data is that we really need to evaluate these novel agents in earlier lines of therapy in a randomized way, so we can really start to impact practice. I think many questions remain about the optimal role of these drugs in earlier lines of therapy. We also saw some data looking at new options after brentuximab vedotin and PD-1 failure in patients with relapsed refractory Hodgkin lymphoma, including updated data from the anti-CD25 antibody drug conjugate CAMI, some data from a study looking at everolimus combined with JAK1 inhibition, and pembrolizumab combined with HDAC inhibition. And thank you for your attention.